Good evening, everyone. I would like to thank you all for taking out your precious time from your busy schedule. This webinar is organized by Banai, Behavioural and Neurosciences Academy of India. Banai is a not for profit organization formed in 2012 and, and has organized more than 200 plus programs nationally and internationally. Focus of Banai is to provide contemporary cutting edge on behavioral neuroscience. Banai is formed and runs under the guidance and chairmanship of Dr. E. Mohandas. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Sanjay Mahendru as the moderator for today's webinar. Thank you, Dr. Sanjay Mahendru, for accepting to be the moderator for the webinar. Dr. Sanjay Mahendru is a graduate from GSVM Medical College, Kanpur. Dr. Sanjay Mahendru has done his MD in Psychiatry from King George's Medical College, Lucknow in the year 2000. Dr. Sanjay Mahendru has attended many national and international psychiatric conferences and has several publications to his credit. Currently, Dr. Sanjay Mahendru, besides being actively involved in practice, is also conducting quality research in the form of clinical drug trials. Dr. Sanjay Mahendru is a psychiatric advisor to Indian Institute of Technology, Kanpur. I would now request Dr. Sanjay Mahendru to take over and start the session proceedings. Over to you, Dr. Sanjay Mahendru.
Thank you, Azhar. Good evening, friends. I would like to introduce our chairpersons for the evening. First to go is Dr. Rahul Chakor. He is a professor and head Department of Neurology, TN Medical College, and BYL Nair Hospital. He has also been the ex-dean Richardson Crudas Jumbo COVID Center, Baikula, Mumbai. He's a consultant neurologist at Prince Alai Khan Saifi Breach Candy and Bokhart Hospitals, Mumbai. He's a postgraduate teacher and examiner for DM and DNB neurology. He has been a principal investigator for multi-center drug trials in multiple sclerosis, migraine, epilepsy, stroke, Parkinson's disease, and dementia. He has 25 publications in national and international peer-reviewed journals. Our second chairperson for the evening is Dr. Jagmohan Vadhava. He's a senior consultant and advisor at the Institute of Psychiatry and Behavior Sciences at Sir Gangaram Hospital in New Delhi. Dr. Vadhava has done MD Psychiatry from AFMC Pune and PhD from NIMHANS Bangalore. Dr. Vadhava has large number of research projects and papers to his credit. Dr. Vadhava has had the pleasure of being research psychiatrist for the first Indo-Soviet space program. He has been the past president of Delhi Psychiatric Society and currently president of IAPP Delhi chapter. I would request Dr. Rahul Chakor to introduce today's topic.
Dr. Rahul, you need to unmute.
Thank you, Dr. Mahendru. I welcome everyone for this interesting session today. The topic is delirium, a medical emergency with psychiatric manifestations. As we all know, delirium is an acute mental status change characterized by abnormal and fluctuation of attention. It is one of the most common cause for referral to a neurologist as well as a psychiatrist in the ICU setting. It is an emergency because either the patient becomes restless, agitated, and is uncontrollable, or the patient becomes drowsy and slips into stupor or progressive drowsiness. Both of these situations are worrisome in the ICU setting for obvious reasons. We will be having the perspective of two very eminent speakers for this topic. Delirium, a medical emergency with psychiatric manifestations. Critical care expert and a psychiatrist. We have Dr. Divatia and Dr. Grover with us to enlighten us on this topic. I'm sure with their expertise, we will be having a really informative and interesting session in Banai. If Dr. Jagmohan is there, I would request him to introduce the speakers.
Hello, I hope I'm audible. I'll introduce Dr. Jigishu Devatia. He is professor and head of the Department of Anesthesiology, Critical Care and Pain at the Tata Memorial Hospital, Mumbai. His postgraduate diploma medical systems symbiosis from Center of Healthcare, Pune. In 2001, he was a past president of Indian Society of Critical Care Medicine. He was the past editor-in-chief of Indian Journal of Anesthesia. He has major interests include hemodynamic monitoring, sepsis, end-of-life care, airway management and organization. He is a member of editorial board and Indian Journal of Critical Care Medicine. He has over 150 publications in national and international journals. He has presentation in several international, national, and state conferences. So, this is in brief about Dr. Devatia. Now I'll introduce Dr. Sandeep Grover, who is a professor, Department of Psychiatry at Postgraduate Institute of Medical Education and Research, Chandigarh. His areas of interest are consultation license psychiatry and psychopharmacology. He has received the Young Psychiatrist Fellowship of the WPA 2008 and 2011, Asian Federation of Psychiatric Association 2012, Pacific Rim College of Psychiatrists 2012, and International Society of Bipolar Disorders 230. He is an associate editor of Indian Journal of Psychiatry 2009 onwards. He is editor Journal of Geriatric Mental Health 2013 onwards. He is associate editor Indian Journal of Psychology, Psychological Medicine 2018 onwards. He is editor Journal of Mental Health and Human Behavior 2018 onwards. He has been awarded thrice ICMR award for his research work. He has 675 publications in peer-reviewed journals and 60 book chapters and edited 4 books. Now I'll request the speakers to start their talk.
Am I audible?
Yes, sir.
Yeah. Thank you, chairpersons, for the kind introduction. I would, at the beginning, I would like to thank Dr. Rajesh Nagpal for inviting me here, and just for the audience, I'd just like to inform them that tomorrow is a World Delirium Day. So this talk collides or is in very close contact with that. So that's where it is a kind of an awareness talk also. So let's try to understand what is delirium. So before I go to my talk, I'd just like to tell that I do not have any conflict of interest when I'm talking on this topic, except that I'm a researcher working in this area. So when we try to understand delirium, again, what we need to understand is the most common psychiatric morbidity which is seen in patients with acute medical illnesses, especially those who are admitted to the inpatient unit or to the intensive care unit. But still, most of these patients are not recognized and henceforth are not treated. And compared to other psychiatric disorders, delirium is the only psychiatric condition I can say for which we just talk about a pure organic etiology. So we do not have a functional equivalent of delirium as compared to when we talk about other psychiatric disorders. And when we try to understand how does it manifest, we need to understand that people always think about that there is decrease in the level of consciousness. I think we need to understand that delirium is not a reduction in the level of consciousness, but it is a disturbance in the content of the consciousness, means that patient is conscious, but is not able to function normally or not able to coherently connect with the society. And many terms have been used depending on the kind of specialty which the people are dealing with, and we hear so many terms being used interchangeably for the word delirium, and these terms are gradually reducing, and now most of the specialty have fortunately started using the term delirium for this condition. And how common this is, let's try to understand. So the prevalence of delirium varies from treatment setting to treatment setting. And as you can see from the slide, in the intensive care unit and those in with the palliative care kind of a care, the incidence of delirium is very high, and the prevalence of delirium is very high. And in elderly, the prevalence is higher compared to that of the adult population. And simply trying to understand that delirium occurs in about 75% of the older adult people who come to the hospital with an acute illness or who undergo any kind of surgery. And why it is important, yeah, why it is important to recognize delirium? We need to understand that delirium is associated with higher rates of psychological distress to the patient and the caregivers. This is associated with higher rate of mortality, longer duration in the hospital stay, higher treatment cost. It is a predisposing factor, the risk factor for developing dementia in the future, and definitely because of the behavioral disturbances, there is a lot of loss of dignity of the patients. And if we try to understand why delirium occurs, but we understand that delirium has multiple etiologies, but there is a similar manifestation. So why does that happen? Different people have tried to give different kind of theories, and at present we understand delirium is usually arise because of a combination of various factors, which include neuronal aging, circadian dysregulation, there's inflammation, oxidative stress, neuroendocrine abnormalities, and all this together contribute to the network disconnectivity, in that sense that different brain areas are not connected well to each other, and that lead to neurotransmitter dysregulation and failure of the brain, manifesting as delirium. And we try to understand the nosology. Almost now DSM-5 and ICD-10-11 are in the same page, and the core symptom of delirium which is recognized is disturbance of attention and awareness. Awareness basically here reflects is the disturbance in the orientation, which develops over the short period of time. There are other cognitive disturbances, but when we try to look at what is the difference between ICD-11 and DSM-5, we need to understand that DSM-5 talks about the so-called not better explained by the pre-existing, but that ICD-11 does not specifically talk about that, and DSM-5 talks about there's a history of and physical examination suggests underlying medical illness or substance abuse and so forth. Whereas ICD-11 talks about the symptoms are not attributable to a disorder or disease which is classified under the mental and behavioral disorders or the substance intoxication or withdrawal or to a medication. So this is a major the basic difference between the two systems. And all of you know how to screen delirium patient, and most commonly used instruments are the CAM, ICU, and DRS can be used for screening and rating the severity of delirium. And CAM ICU has 4 basic components, that is, it assesses the acute onset and the fluctuating course, inattention, disorganized thinking, and the altered level of consciousness. Although you can see that there is altered level of consciousness, the word being used, but again, we need to understand that this is not the core symptom of delirium as we now understand. And for ICU patient, we use CAM ICU, which is again an adaptation of CAM. And again, here we assess the same 4 components of delirium. And there are various differential diagnoses for delirium as we try to understand, and it varies from all kind of psychiatric disorders to different kind of physical illnesses which can mimic delirium. And especially in cases of patients with delirium tremens, those who come with alcohol withdrawal kind of a delirium, we need to be very, very conscious and look for other factors which can mimic delirium, which can include some kind of a head injury, subdural hematoma, or Wernicke's encephalopathy, or to that matter, hepatic encephalopathy, or hypoxia, sepsis, and other factors which come in as a complication of delirium tremens. And in terms of hepatic encephalopathy, we need to understand that if you closely look at the patient, if you take a proper history, you will understand that the stage 2 and stage 3 of hepatic encephalopathy may mimic delirium. But if you properly look at that, there is a slurring of speech, there is flapping tremors, and there are hypoactive reflexes, which will indicate that patient is in HE, because HE will require some amount of different kind of a management, as we understand as psychiatrists. But from that point of view, slight differences are there. And stage 3, you can see hyperactive reflexes, nystagmus or Babinski sign, clonus, rigidity, and so forth. So it's very, very important to carry out a detailed physical evaluation. And in terms of HE, we need to understand that delirium usually is similar to some kind of an overt kind of a hepatic encephalopathy rather than a covert, or the minimal HE is not similar to delirium. So in terms of assessment of delirium, we need to understand the 3 basic components, that is the history taking, examination, and carrying out the investigations. In terms of history, I think we need to be very, very clear that we need to focus on the onset and the course of the symptoms, because understanding the onset, because we need to have acute onset and the course in terms of the fluctuations, and you need to take the past and the current medical history, understand the pre-morbid cognitive status, past psychiatric history, what are the current ongoing medication and the substances which the patient is taking, and if he was taking substance, when did he take the substance last. And in terms of risk factors are broadly classified as predisposing factors or the etiological factors, and some of the simple mnemonics which can be used to remember this. But the most important things to remember, that any kind of sensory deprivation, either visual or auditory, use of over-the-counter medication, more severe the physical illnesses, more physical functional disability in elderly, those who have cognitive decline or the dementia, those who are being prescribed too many medications, who have comorbid physical illness, alcohol abuse, and it is reported to be more in among males, and those who have malnutrition. So if you want to just remember a mnemonic, it's a suspect CAM. So that's where you'll remember. But the most important thing which we need to understand, that if a person is receiving more than 3 medication, has malnutrition, has undergone a surgical procedure or any kind of a hospital procedure, has an in situ bladder catheter, or is physically restrained, all these factors predispose a person with medical illness to develop delirium. And in terms of other etiological factors which are directly linked to development delirium, again, simple mnemonics like pinch me, that is pain, infection, nutrition, constipation, dehydration, medications, and environment factors needs to be remembered. Or the other mnemonic is I watch death. I am sure that all of you know that. Or if you can remember the mnemonic itself as delirium or as dementia. So there are different mnemonics to remember the etiological factors of delirium. But certain conditions which are very, very life-threatening needs to be remembered when you're looking for delirium, and that is where your investigation and physical examination need to focus on that, especially in patients with alcohol withdrawal, Wernicke's encephalopathy should be looked at, and those with history of diabetes, hypertension, you need to look for hypertensive crisis or hypoglycemia or hypothermia and so forth. And in terms of medication, again, although we talk about steroids and anti-Parkinsonian drugs or those with high anticholinergic properties to be causative factor for developing delirium, but we need to understand almost all kind of medications can cause delirium, and that's where high index of suspicion is required. And in that, the anticholinergic properties of the drug can be looked at. Now you have online or anticholinergic property calculators as ACB calculators, which can rate the drugs depending on the anticholinergic activity as 1, 2, and 3. And this can guide you in understanding which medication to change first, which to stop, and so forth. So that's why online calculators can be used for any kind of medication which the patient is receiving in the list. You need to check those things for the patient. And that is where reviewing the so-called prescription and stopping the non-required medications comes into picture. And those with delirium tremens, you need to understand that there are specific risk factors which you need to look for. That if a person has been taking heavy alcohol, has past history of DT and seizures, has higher severity of alcohol withdrawal, is an elderly, or there's a genetic predisposition to develop delirium or DT, you need to understand these people are at a higher risk of developing DTA, so preventive measures need to be put into place as soon as possible. And the other factors which you need to remember are the so-called electrolyte disturbances and decompensation of acute or the chronic medical conditions. So when we are looking at the acute metabolic disturbance, we need to understand that this may be actually secondary to DT itself, and which to the withdrawal itself, and then it can lead to DT. In terms of examination, I think this is something which is mostly ignored by the psychiatrist colleagues. We don't focus on the physical examination of the patients, but we need to understand carrying out a detailed neurological examination, looking for proper signs of dehydration, looking for the nutritional status, looking for evidence of sepsis, and considering all possible differential diagnosis. We need to focus on that, and we need to understand that a head-to-toe examination can give you a lot of hints about what could be the possible cause of delirium. Maybe if you have dilated pupil or constricted pupil, you can know that maybe patient has opioid intoxication, or henceforth other factors can be looked at, and you need to understand if the patient has papilledema, it may be related to hypertension, or there should be hypertensive crisis, and so forth. So carrying out a good physical examination is one of the most important aspects for delirium, which we all need to understand. And in terms of in patients of delirium tremens, we need to look for other decompensation, that is the cardiac decompensation, sources, so-called GI bleed, pancreatitis, infection, liver diseases, and look for head injury, constipation, and check for fever. Because all these are very, very important. They can give you leads how to go further, or what all factors to focus in managing a patient with DT. And in terms of investigation, the basic panel should include the routine investigation, electrolytes, and other stuff. But getting serum ammonia levels and magnesium level in patient with alcohol withdrawal delirium should be considered, because this can be very, very helpful. And neuroimaging and EEG can again be considered depending on the kind of lesion history and the physical examination findings. And you need to, if you find any abnormalities, you need to monitor them very closely. In patients with DT, the investigation can further be carried out, but what we need to look at in the patients of DT is that ECG, you should be very careful and looking for the cardiac arrhythmias. You should look for pancreatic enzymes, which can give you indication about the pancreatic decompensation. Look for the serum ammonia levels and the acid-base balance, and MRI and echocardiography, because MRI can give you some hints about the Wernicke's encephalopathy, and CSF can give you if there's a secondary infection and if there's a patient has fever, you can if you're suspecting meningitis or encephalitis, you can get findings for that. What are the important steps in the management of delirium? What we need to understand, that most important step as a psychiatrist is to communicate with the colleague about the possibility, and also with the other treating team members, whoever are involved. Means when I say colleague, means we usually end up talking to, let's say, a physician colleague, a junior resident, a senior resident, but we don't talk to the nursing staff, other staff available around. We need to focus on them, also tell them what this patient is going through, because they are the people who are dealing with the patient more often and throughout the day, rather than the consultants on round or the residents who are coming for some time. So those people who are more on the duty hours and who have more close contact with the patient, we need to discuss with them and tell them the possibility and what is to be done. And we need to discuss about the reversible etiological agents and the implicating medications, and try to stop or change whatever is feasible. And then we need to communicate with the family members who are staying with the patient, because many times family members suddenly gets, if the patient has visual hallucination, auditory hallucination, getting severely agitated, they think something has gone wrong. And in India, we know that people believe in black magic and so forth. They will think that suddenly some black magic has happened, and they may ask for lama, take the patient home, and so forth. So we need to understand, we need to communicate with them, tell them clearly that what the patient is going through. In terms of management, the most important step is managing the underlying cause and the non-pharmacological management, and then comes the pharmacological management. We need to understand that pharmacological management is not everything, and it is the last thing to be done. First and foremost things which are is looking for the underlying cause and carrying out the non-pharmacological measures. And in terms of the non-pharmacological measures, what we need to look at, or we need to understand, is that the next first thing to understand is looking for the cause, and we need to remove the offending agent if it's a medication or it's an electrolyte disturbance. And as I've already said, that using the ABC classification to categorize the medication for their anticholinergic propensities and changing them, and removing all the unnecessary medications, and trying to treat the underlying infections with appropriate antibiotics. And if the patient has poisoning or intoxication, they need to use the appropriate antidotes. And if it is delirium-related alcohol withdrawal, benzodiazepine and thiamine should be considered. The most important non-pharmacological measures include focusing on the patient's sleep, talking about the reorientation, and frequently reorienting the patient, trying to put the patient under relaxation, some kind that they're not worried, they're not fearful, ensuring adequate pain relief, And as soon as patient is able to move around, we need to encourage mobility and have good communication with the patient, family members, ensure good hydration, and prevent complications. In terms of supportive measures, we again need to understand that immobility is something which we need to avoid, and we need to take measures that there are no pressure sores being developed, bladder bowel habits are being maintained, and that we need to monitor the prescription with special focus on evaluation of potential adverse drug-drug interactions and the drug-disease interactions. Frequent orientation, which involves speaking very clearly to the patient and having a provision of clock and calendar with the patient in the room so that patient can be oriented from time to time, and maintaining the competence, focusing that if the patient requires an hearing aid, glasses, those needs to be provided. If patient requires an interpreter, you use the language which patient understands that you are not able to use, maybe that may be useful. And encouraging the patient to participate in the treatment, because although patient is in delirium, at times they have the lucid interval, so we need to be encouraging them to participate in their treatment. And whenever they're in the lucid interval, they need to be made aware that what they are going through, and we need to arrange treatment for other things which the patient require. Physical restraint needs to be avoided wherever possible, and if at all these are used, they should be used for a very short duration. And the most important thing which I just want to again emphasize, that when you're talking to the nursing staff and other so-called paramedical staff, they need to be told that because the patient have a severe disturbance of sleep, they should schedule the treatment, intervention, or IV fluids in such a way that the patient can have maximum period of uninterrupted sleep. It's not that patient has interrupted sleep and suddenly at 2 p.m. they so-called something is due, so you go and wake up and the patient and then give. It should not be done that way, especially in a patient of delirium. We need to schedule things according to the need of the patient. And again, in terms of making proper eye contact, frequently touching the patient to reassure, having clear signposts for the patient's location, clock, calendar, bringing familiar objects from the home, and ensuring consistency of the staff, that is avoiding frequent change of staff, is again very, very important in managing a patient of delirium. And we need to be very, very clear in terms of the area where we are managing the patient. If possible, put the patient in a single room, avoid unnecessary changes, avoid clutter around the patient. And when you're going to the bedside and trying to talk to the patient, or you're trying to talk to your colleague, avoid use of medical jargons, because this may again induce paranoia. And you need to, if you want to discuss something, you can come away from the patient bed and then discuss. Okay. And in terms of pharmacological management, again, we need to understand that different agents are being used, like antipsychotics, benzodiazepines, acetylcholine inhibitors, or alpha-2 adrenergic receptor antagonists like dexmedetomidine, and melatonin has been used in recent times, and these all have also been tried in combinations. So in terms of delirium, which is not associated with use of alcohol, antipsychotics are the mainstay of treatment, and benzodiazepine should be only limited to people with alcohol withdrawal delirium. And in terms of antipsychotics, haloperidol is the most commonly recommended drugs, although we have recent evidence for use for atypical antipsychotics. And what we need to understand that we should start antipsychotics with a lower dose and gradually titrate. And whenever we are trying to use a pharmacological agent, we need to weigh the risk and the benefits, and it should be discussed with the family, caregivers, and other primary treating team members, that why we are thinking of giving an antipsychotics, getting a baseline EEG done to monitor the QTC interval, and clearly documenting why antipsychotics are being started. And we need to monitor the symptoms over the time period, and we need to avoid any kind of oversedation or extrapyramidal side effects. And we need to remember this basic dictum that antipsychotics should not be used in patients with hypoactive delirium. And when you're trying to choose the different agent, you need to keep in mind the issues of QTC interval, sedation, anticholinergic effects, and the orthostatic hypotension, because these are elderly patients, they may have a risk of fall. So from all that point of view, haloperidol has low potential for all this, and that is why haloperidol scores over other molecules. The other molecule which comes slightly closer to haloperidol may be olanzapine, but we need to understand with so much of physical comorbidity, olanzapine can have its own complications. In terms of other medication, the evidence is very, very low. So at present, it's very difficult to make any recommendation. And in terms of melatonin, the evidence is available in terms of prevention of delirium. For treatment of delirium, the evidence is emerging, but it's not very convincing at this moment. And when we're trying to manage a patient with alcohol withdrawal delirium, the basic aim should be to control agitation rapidly and adequately. We need to decrease the risk of seizures, decrease the risk of injury and death, and minimize the complications and prevent and treat the wernicke's encephalopathy. The basic principles again to be remembered that IV fluids, if you are using, should not be, if you are using thiamine, and you should not give IV fluids. Thiamine should be given before giving so-called IV fluids which have glucose and those kind of things, because otherwise it can lead to another complications. And we need to manage the fluid imbalance, the electrolyte disturbances, and the nutritional issues. And magnesium sulfate, although it has not been shown to be very effective in managing the withdrawal per se, but it should be supplemented in patients those who have hypomagnesemia, because it is suggested by some of the authors that thiamine also don't act well, and the benzodiazepine also don't act well in patients those who have hypomagnesemia. And there are different kind of regimens which have been talked about, the front-loading regimen or the symptom-triggered regimen, and the drugs which you want to use, like something like diazepam and lorazepam. Lorazepam should be preferred in patients those who have hepatic dysfunction, and the preferred route is of the IV. And the target should be achieving a light dosing kind of the patient slightly sedated, not that patient is fully sedated. And we need to monitor the vital signs of the patient when you're using the benzodiazepines. And we need to balance between the unnecessary high doses of medication and the doses which are required to control the withdrawal sufficiently. And we need to individualize the dose. So different dosing regimens are being talked about. The front loading, you will use higher doses within first few hours, whereas symptom triggered will require that initially use your higher doses. Once you stabilize it, then you come with the slower doses. So diazepam has its own regimen, and the lorazepam has its own regimen, and people have tried different kind of regimens in patients with DT. In terms of choosing the agents, we need to understand that diazepam can rapidly control the agitation, and it has a longer half-life, so it can avoid the breakthrough kind of symptoms, whereas lorazepam is safe in patients with liver dysfunction, elderly, and those who have concurrent medical illnesses. There, where you want something like you want to avoid some kind of respiratory depression or other things in the long term, lorazepam may be preferred. But when you're using lorazepam, you need to remember that you need to withdraw it very slowly. And if you are not able to manage or use benzodiazepine in patients with DT, different other medications have been talked about in the literature, something like phenobarbital, propofol, dexmedetomidine, and so forth. I have seen people using propofol and dexmedetomidine if it is required, but you need to understand when you're using propofol, you need to be very, very cautious about the issues related to the heart block. And when you're using neuroleptics like haloperidol, which you need to understand that haloperidol alone is not going to work, you need to combine it with benzodiazepines. And the other agents which have been tried include the atenolol, beta blockers, clonidine, and phenytoin. But again, you need to understand the evidence is not very robust for all this, and you need to carry out the monitoring for these agents, because all those will come with a different kind of side effect profile. Especially beta blockers can lead to hypotension, bradycardia, and the alpha-adrenergic blockers, energetic agents can also lead to hypertension, tachycardia, anxiety, and trauma, which may actually mimic alcohol withdrawal, and you may end up using higher doses of benzodiazepines. And you need to again understand there are people who are at a risk of wernicke's encephalopathy, those who have DT in the past, or there's those who are currently having DT are more likely to develop wernicke's encephalopathy. And those who have severe alcohol dependence have a lot of concurrent physical and mental illness, history of seizures. There are repeated unsuccessful attempts at medically assisted withdrawal or detoxification. These are the people who are at high risk of developing wernicke's encephalopathy. So we need to understand here that higher doses of thiamine are required, that you need to start with 500 milligram IV 3 times a daily for first 2 to 3 days, then shift to 250 milligram daily for next 3 to 5 days, and then you shift to something like 100 milligrams 3 times daily for the rest of the hospital stay, and then gradually you need to reduce the dose, and never start dextrose before the use of thiamine. And magnesium sulfate can be used with thiamine, because hypomagnesemia, as I said, can lead to non-effectiveness of thiamine. And if a patient has hepatic encephalopathy, which is again so often present in patients with DT, you need to make sure that patient bowel habits are clear, and you may use the lactulose, rifaximin, and need to understand that you need to give the protein related diets. And when you're using that, you need to preferably advise for vegetable based proteins. And the other preventive strategies, which are again very important to understand, that stimulating the mind, mobilizing the patient as early as possible, making them sleep on time, ensuring that sensory deprivation is taken care, hydration is maintained, and food is being given. So we all understand this ABC DEF bundle for management and prevention of delirium. So we all need to follow that, especially those who are in ICUs. They need to avoid over sedation and try to give so-called spontaneous breathing trials from time to time. So, and in terms of other preventive measures, all patients should undergo cognitive functioning evaluation at the baseline. We need to evaluate the risk factors. We need to monitor the cognitive functions, make sure that if the patient has sensory deprivation, the preventive measures are put into place, and medication needs to be looked at, where you need to weigh the risk and benefits of using certain medications, especially those with high anticholinergic properties. And whenever you are using medications in patients with medical illnesses, especially in the hospital, we need to avoid polypharmacy and maintain the environment of the hospital in such that the risk of delirium is reduced. And we need to reduce the immobility, avoid physical restraints, and provide quiet environment to the patient and minimize the use of indwelling catheters. So to conclude, delirium is a medical emergency, which is rather than a pure psychiatric emergency, but definitely it is a psychiatric condition which is related to underlying medical illnesses, and management involves prompt detection, institution of appropriate pharmacotherapy, and comprehensive management includes proper assessment, pharmacotherapy, supportive care, prevention, and management of complications. Thank you. Thank you, sir. I've done. You can go ahead, sir.
Okay, thank you. Okay, thank you very much for this invitation to speak at this meeting. Thank Dr. Mittal for inviting me. And on this eve of Delirium Day, Dr. Grover has given a wonderful background, so I can hopefully try and cover up the specific parts related to delirium in the ICU. Now, why am I someone who's an anesthetist and intensivist talking about delirium in the ICU? Firstly, I think delirium has been around for a long time in the intensive care unit, but unfortunately, it always got the nomenclature of ICU psychosis. And it was a very poorly understood and a rather misunderstood syndrome. It was rarely diagnosed. It's only now in the last 15 years or so that we've sort of come to grips with what we are dealing with. And we now know that, patients, many patients who have an acute illness often have disturbances of attention, cognition, and it's not uncommon at all. Let's say for a 70-year-old man, when he gets a pneumonia, he may not be overtly breathless, he may not be overly hypotensive, but he may just become confused. He doesn't know where he is. He's not wearing his clothes properly. And to me, that person is at a very high risk of developing severe complications and even sepsis, because that's the way the infection has sort of taken hold of him and is producing a sort of acute encephalopathy, right? And the other reason why intensive care is interested in delirium is that very often delirium could be a sign of a very serious underlying disorder. It's not just enough to say this patient is confused, or he's not behaving properly, or he doesn't understand where he doesn't know what he's doing. But all these things could actually be a sign of a very serious underlying disorder. And we all heard of all those disorders that could be there. And very commonly, infections and sepsis is extremely important. I will not go into any of the withdrawal syndromes, especially alcohol withdrawal, because Dr. Grover extensively dealt with alcohol withdrawal and delirium tremens. And most of my talk will focus on the general sort of intensive care patients and the delirium that we see in them. So, now I think the terminology has evolved so that we recognize only two really broad terms. We don't really talk like we used to talk now of acute confusion state or, all those other terms. But one is acute encephalopathy, which is a rapidly developing process, usually within 4 weeks, due to a pathobiological process within the brain. And this encephalopathy can lead to various presentations, including delirium or even coma. So encephalopathy is a process which results in delirium. And we've seen what delirium is, and delirium is actually a very specific sort of diagnosis, which is based on a combination of features as defined by the DSM-5. And like we heard, you have disturbance in attention and awareness, which occurs over a short period of time. And it very often tends to fluctuate. And I think this fluctuation is a very important part of delirium. It is not uncommon for me to have taken a round in the morning and found the patient is fine, and then to come back in the afternoon and find that now there's something not right with this patient. So the fluctuation is extremely important. And you can actually have people disagreeing with each other, saying that, no, when I saw him, he was fine, but then, but you saw him, but he was not fine, So there is a fluctuation which is quite characteristic with these sort of things, right? And then, of course, there's a cognitive defect, and these are not explained by any other sort of disorders. And you can actually pinpoint or identify an underlying disorder which has given rise to this syndrome. Now, depending on what sort of patient cohort is being reported, the incidence of delirium in the ICU varies. And it can go as high as 82% in medical ICU patients who are the sickest, and up to 70% in patients who are mechanically ventilated. And once we understand the pathophysiology of delirium, we can understand why it can be so high in some of these patients. And in some patients who are basically surgical patients, like those undergoing CABG or after stroke, incidence could be a little lower. But this one meta-analysis, the pooled prevalence of about 32% in ventilated and non-ventilated patients. So why does delirium occur? So it is an interaction between an underlying predisposition, on top of which we've got an acute stressor. So there are predisposing factors and there are precipitating factors. And the predisposing factors are things like old age, a history of alcohol, and many other things which we'll talk about. On top of which you now have a precipitating factor. The common ones are like infection, sepsis, trauma, and trauma includes major surgery, right? Then it could include alcohol withdrawal. It could use many drugs which could be given. Polypharmacy is not uncommon in the intensive care unit. So you have this combination of a precipitating factor which works on a predisposing factor, and that eventually leads to delirium. And there are various theories. So when you have predisposing factors, there is some vulnerability of the brain. There is a degeneration of the brain, or there is some vulnerability of various components of neural tissue, which then get acted upon by a stressing or a precipitating factor. So you have changes in brain connectivity, which is because of aging or neurodegeneration. And very importantly, these aging or these microglia and astrocytes, if they are impaired, they are actually primed by neurodegeneration to produce exaggerated inflammatory responses. And in cases of trauma, sepsis, infection, you have a systemic inflammatory response. And this, when these inflammatory mediators reach the brain via leaky blood-brain barrier, if the microglia and the astrocytes are already primed, they exhibit exaggerated responses within the brain and can lead to uh, delirium, or what we call as acute brain dysfunction is one way of looking at it. So it may be part of a multi-system organ dysfunction, of which the brain is one system which seems to be affected, right? And there are vascular changes. There may be hypoperfusion. There may be reduced the permeability of the brain's endothelium of the vessels may be abnormal, and again it can cause leakiness of the blood-brain barrier, and that allows drugs to get into the brain. It allows cytokines to get into the brain, and all of which can create a sort of soup in which the brain bears the brunt of this thing. Right now, on top of this, so you've got a brain which is vulnerable to damage, and then you actually have damage which occurs, and that damage can occur in the form of hypoxia, which leads to impaired brain energy metabolism, right? So there's anaerobic metabolism occurs, you have microvascular alterations, and this can happen because of shock, hypovolemia, hypotension. You can have hypoglycemia, and you can, even with normal blood sugar levels, there could be impaired glucose transport and utilization, which leads to reduced glucose utilization by the brain, and all that can impair the energy metabolism of the brain. And this inflammation, like I said, can flare up the whole syndrome, and in addition to inflammation, inflammation also activates coagulation, which can also lead to further vascular abnormalities and hypoperfusion. And as was mentioned, drugs are very important and very much part of the problem. The drugs that we use to treat other things, your antibiotics, your other drugs, many of them could have anticholinergic effects, and they can upset the balance between the cholinergic, noradrenergic, and dopaminergic systems. Unfortunately, the balance between these and how the drugs interact is very poorly understood, and that is why in a lot of these patients, pharmacological management is not all that useful as we would like it to be, right? So there are also, you have a vulnerable brain on which you have imposed precipitating factors, and that those cause lead to delirium. In some cases, you might actually find electro EEG changes. So there will be some changes in the EEG. Very often, it's in the form of slowing down of the EEG, and there is some, in few, not all cases, but in some cases, you will find some evidence of neuronal damage by looking at some of these biomarkers of neuronal damage. You can see that in some patients who have got sepsis-induced delirium in patients with sepsis, you may get these findings in the white matter. Uh, the problem with doing MRI and finding these lesions is you don't know at what stage you should be doing the MRI. And if you do it at the wrong time, you may not find changes, or there might be some other mechanisms which may be also leading to uh, changes in the white matter, which you see in MRI. But again, this is not very common, but it's not uncommon either to see changes in the brain. So if you sort of sum up the major mechanisms in the pathophysiology of delirium, right, you'll find that, so these things, the microglia are vulnerable because of degeneration. The astrocytes are also vulnerable because of degeneration. There's vascular dysfunction and blood-brain barrier dysfunction. And on top of this, you've got acute cellular changes, which happen because of inflammatory mediators. It happens because of microvascular dysfunction and all those sorts of things. And all that sort of, and you've got systemic triggers like inflammation, hypoxia, reduced blood flow due to shock or hypovolemia. You've got metabolic derangements like hyponatremia, hypoglycemia, and all of these lead to some disturbances in the neurotransmitters, some disturbances, so hyperinflammation in the brain, and all of that can lead to the syndrome that we recognize as delirium. And having understood the pathophysiology or the pathobiology of delirium, it is easy to understand the risk factors and identify the risk factors for delirium. So those which lead to neurodegeneration, for example, advanced age, pre-existing dementia, okay, a lot of comorbidities which may be there, and it's not on like diabetes, hypertension, ischemic heart disease, frailty. Frailty is also very important. Patients who have some sort of impairment of vision and hearing, those who are depressed, those who have alcohol abuse, poor nutrition, all these factors have been identified. Past history of delirium, excessive smoking, use or excessive use of alcohol or opioids, and again, can all predispose to delirium. On top of this, you've got surgical stress because an inflammation and activation of the stress hypothalamic pituitary axis and the stress response to surgery and trauma. So the greater the magnitude of the surgery, the greater is the risk of delirium, right? You got severe illness, which is why the patient may have come to the ICU. So let me put it this way: most patients, except let's say maybe things like delirium tremens or severe alcohol withdrawal, most patients do not come to the ICU with delirium. They develop delirium in the ICU, and they develop delirium in the ICU because they've got risk factors and because they've got an underlying problem which can cause delirium, and the things that we do to them in the ICU that can cause delirium. And some of the things that we do to the patients that cause delirium is we put them on ventilators. In order for them to tolerate tubes and devices and ventilators, we give them sedation. So sedation is very bad. Patients have pain because of all the procedures and so on that we do. They cannot sleep in the ICU because there are so many patients. There are lots of alarms. There's lots of activity. The sleep is completely disturbed. There's polypharmacy. If they are sedated, the lights in the ICU are on all the time. Even if you dim them, it's not the same as having a day and night sort of shift. So all those sort of things lead to delirium in the intensive care unit. Sometimes we restrain patients, which is not good. But one of the very, very important things that we have learned is that sedatives, which we used to use so commonly in the intensive care unit because they want to sedate patients, you want to keep them comfortable. We thought it was a humane thing to do. But the common drugs that we use, especially the benzodiazepines, are extremely likely to cause delirium. And in fact, they are triggers for delirium, right? So we need to avoid many drugs, but sedatives and benzodiazepines are now actually we our use of benzodiazepines has gone down considerably once they were identified as risk factors for delirium. There are risk scores which sort of can predict delirium, but I guess if you just keep all the risk factors in mind, you will come to know, that whether this patient is at high risk of delirium or not. And most intensive care patients will be at high risk of delirium. Why should we worry? It's a predictor for mortality. The risk of death is higher if patients have got delirium. And the longer the duration persists, the higher is the risk of delirium and of mortality. So as your duration of delirium persists, you can see that your mortality keeps increasing. And of course, it increases hospital stay, and because of that, it increases costs. So it has all the impairments, and very importantly, there is post-discharge cognitive impairment. So even after the patients have survived intensive care, they've recovered from delirium. If they've had delirium, then they are more likely, twice as likely, to have cognitive impairment at hospital discharge. Okay, and this is some nice. If you can see that this is a template that they were asked to copy, and patients who did not have delirium drew something like this, and severely impaired patients drew something like this. Right now, so patients now, we have seen that patients who have recovered from sepsis, septic shock, ARDS, they have cognitive the disability at discharge, and some of it is because of delirium. So we need to work on delirium to improve the post-discharge quality of life. And patients who have had delirium not only have had cognitive impairment and they cannot work well, or they cannot go back to their normal work, but they could have physical disability, and very importantly, they could have depression and maybe even PTSD, and all that leads to a poor quality of life. So in short, delirium is bad. It is associated with increased post-discharge mortality, and in some studies, new institutionalization and dementia. Okay? And older patients, frail patients, patients who have hypoactive delirium and who have longer duration and severe delirium are fare much worse than others. And we've heard that in the ICU, the method that we use most commonly, the one we used in our ICU, is the CAM ICU method. And it's a simple way of sort of doing it. It takes less than 2 minutes. It has been shown to have a pooled sensitivity of 80% and a pooled specificity of 96%. So it's a very good tool and very easy to use. The nurses use it, and it's usually done in every shift in the intensive care unit. And this is that flow chart which we use. And these have been translated. If you go to this ICU, if you go to the website, it has been translated into many Indian languages. So you can actually use this in Indian languages and do this, right? Uh, we know that there is some problem with consciousness or alertness, and we use a RASS, the Richmond Agitation Sedation Scale. And the good thing about the scale, a unique thing is about the scale, does not just look at whether the patient is drowsy or lightly sedated or deeply sedated, but it also looks at eye contact, and that gives you a better idea of how the patient is responding to you. Now, when I was much younger, and delirium to me was like the picture of alcohol withdrawal and delirium tremens. Is a patient who's violent, who's agitated, who's shouting, who's jumping off the bed, who's slapping the nurses and other doctors around. And we've seen that happen. But by and large, the most common type of delirium is not the hyperactive delirium which we just talked about. It is the hypoactive. These patients are quiet. They look quite okay. In fact, they may be a little on the drowsy side. They are arousable, but they may be a little on the drowsy side. And they have cognitive defects. And if you examine them, if you don't examine them, they might look perfectly normal. They might say, oh, I might think, oh, this patient is looking good. He's not agitated. He's quiet, looks quite composed and seems to be quite relaxed in bed. But if you do the CAM ICU, you will get in many patients, you will get signs of inattention and disorganized thinking. So these are the patients you have to worry about. And because most of the patients in the intensive care unit actually have hypoactive delirium, and some have mixed delirium, and sometimes they are hypoactive and sometimes they're slightly hyperactive. Okay. There are another tool called the intensive care delirium screening checklist, which has been described. We've not used this, so I don't really know much about it, but this is another tool which is there in the literature. So what happens when we sort of find patients with delirium? Of course, we need to make sure that in any patient who comes in who's sick, if you want to prevent delirium, you need to make sure that you've restored perfusion, you've resuscitated the patient hemodynamically, corrected his blood pressure, his oxygenation, corrected all the metabolic derangements. And then once the patient is settled, you start to diagnose, monitor and diagnose delirium. That is, we do as part of routine monitoring. We monitor sedation, we monitor analgesia, and we also monitor delirium by using the CAM ICU. Then you need to go through the precipitating factors, and Dr. Grover has given you extensively what sort of clinical examination, laboratory tests you do. By and large, you don't need EEG, LP, CT, MRI. But of course, if you don't know what's happening, or if the patient is not doing well or getting worse, you may need neurological help and as well as some of these investigations. But very importantly, what we do now is for all patients who get ventilated, we try to give them as light sedation as is possible. So light sedation, we try to accelerate weaning from ventilation, and hopefully that will reduce the duration of exposure to sedatives and other drugs. Thiamine is very important. Now, thiamine is important, I think, not only in alcohol withdrawal, but in eh, many patients who've come sick, who've had major surgery, who've come with sepsis. Thiamine may play a role, because thiamine plays a role not only in the sepsis, the metabolism of sepsis and the lactate metabolism, but it may have some role to play in some of the CNS manifestations of sepsis that we see. But this is not really evidence-based, so hence I've put a question mark. When we see patients with sepsis, or when we screen patients for sepsis, one of the very important points that we look at is altered ventilation. So altered ventilation, and usually it's never not unconscious, it's just a Glasgow Coma score, which is 1 or 2 less than the standard for 15 by 15. It is a very important. So alteration of consciousness, alteration of thought, a patient appearing confused are all red flags. They signify delirium and a serious underlying disorder. How do we manage it? There are multiple ways of sort of doing it, and this sort of thing is called a multi-component intervention. And in the ICU, especially in multi-component interventions, is light sedations, avoid benzodiazepines as far as possible for sedation, and early mobilization. Right? We've talked about all the other things, but early mobilization is another very important thing. And sometimes we say that, oh, the patient is on noradrenaline, he's on vasopressors, how do we mobilize? He's on a ventilator, how do you mobilize? But it is possible. And with good physiotherapists, with good nursing, even patients who are on oxygen, who are on a ventilator, can be made to stand in bed, walk a few steps, and safely undergo mobilization. Now, early mobilization is good because it gets patients off the ventilators faster, it preserves muscle strength, and may also reduce delirium. And therefore, we have this bundle called the ABCDF, or the A to F bundle, in which consists of assess, prevent, and manage pain. So you need to take care of analgesia. Spontaneous awakening and breathing trials are basically strategies to wean the patients faster off ventilators. Choice of analgesic exposure and choice of sedative exposure, and we'll talk about that. Assess delirium, assess, prevent, and manage, and family engagement and empowerment. So all these things can help reduce the incidence of delirium. And this is a study which has been done in over 15,000 patients from 68 ICUs. And if there is more than a 60 to 80% compliance with the ABCDF bundle, you find that as the compliance increases beyond 60%, you'll find that incidence of delirium reduces and all the other things reduce, right? Time of ventilation and incidence of coma all reduce. So it's a good thing to follow, not just to prevent delirium, but in the overall good general care of the patient. Unfortunately, it has been difficult to show in randomized controlled trials that these non-pharmacological means make a difference to delirium. They help in some way, but if you're looking very specifically to look at only delirium prevention, we've not been able to show it. And the number of trials and the number of patients anyway, not too many. But I think it's still a very good reason not a good reason not to do these good things, because all these things are very good for the overall care of the patient. Can we prevent delirium by pharmacological means? And as an intensivist, I mean, I would just love it, instead of doing so many things and non-pharmacological things. If you could have one or two drugs which can prevent delirium, it would be fantastic. But unfortunately, this has not happened. And in fact, by most of the studies have shown no effect. And the largest no effect on of even not just haloperidol, but even the newer antipsychotics like ziprasidone did not reduce the incidence of delirium. Uh, what does seem to work is dexmedetomidine. Right now, this is a alpha 2 agonist. It's a bada bhai of clonidine, and it again reduces the noradrenaline, the sympathetic responses from the brain, and attenuates from the spinal cord level. And basically, it results in a patient who's calm, who's quiet, but can be easily awakened, and there is no risk of respiratory depression. So it's a very good drug to use. It does cause bradycardia and hypotension, so it has to be monitored. And this is a meta-analysis of 3 or 4 big studies which suggested that if in the ICU, if you sedated with patient with dexmedetomidine instead of either propofol or midazolam, so instead of propofol or midazolam, which are both GABA agonists, then you actually have reduced delirium. So we often use delirium in patients who are coming off the ventilator. We stop all the other sedatives, but the patient still needs some sedation. So then we use dexmedetomidine because that helps the patient stay awake better, also reduces delirium, and we can get patients off ventilator faster. And again, it's a very recent study which has been published, the SPICE-3 trial. Patients who got dexmedetomidine sedation compared to usual care had a much lower incidence of delirium. Once the patient gets delirium, can we actually treat the delirium effectively? And again, like it was mentioned earlier, we don't need to treat hypoactive delirium. What you need to treat is hyperactive delirium. And if you lump all deliriums together, then you're not going to get a benefit with any of these patients. And in fact, what most studies have shown is that, use of antipsychotics like haloperidol or olanzapine does not work. One very small study showed that quetiapine was better than placebo in patients who failed after receiving haloperidol. Rivastigmine in one trial actually found a worse outcome in patients who received rivastigmine, which is a anticholinesterase drug. Okay, and dexmedetomidine resolved delirium earlier. So maybe dexmedetomidine may not just prevent delirium; it may even be effective in treating delirium. And this, the biggest trial so far of any antipsychotic which has been done in treating delirium, has been this MIND USA trial in 566 patients, and no effects on either days alive without delirium or days with delirium or days with coma. So antipsychotics are not very, very effective. And therefore the Society of Critical Care Medicine USA practice guidelines suggest that you should use a multi-component non-pharmacological intervention that may reduce delirium, but also does other things like optimize sleep, mobility, and so on. They recommend that you should use tools to validate delirium. Do not routinely use haloperidol or other drugs to prevent delirium. Do not use them to treat subsyndromal delirium. Do not routinely use haloperidol to treat delirium. And they suggest that if at all you have to use something, it should be dexmedetomidine, at least initially. Although for severe agitation, we do resort to haloperidol, which is our favorite because it can be given IV, and like it was mentioned, is extremely safe when it's given IV for a short period of time. What happens in the real world despite all this knowledge about delirium? This is a survey which was done in 2004 in the US. And while most people acknowledge that delirium is a significant and serious problem, only 40% routinely screened for delirium. And it was treated with haloperidol by 66%, lorazepam by 12%, although it's a precipitating factor, and atypical antipsychotics by less than 5%. So there was a disconnect between the significance of delirium that was perceived and the actual practices. In India, this was a survey which was done some time ago, about eight years ago. And here they found that compliance with the guidelines was low. Benzos were the prominent sedative used, although we know that they are the major precipitants of delirium. Delirium was under-recognized, and monitoring of sedation, analgesia, and delirium was low. And the recommended scales were rarely used. And although people were aware of the benefits of early mobilization, its implementation was poor. So a lot remains to be done. And today, in these days of COVID-19, a quick word about what happens is, I have seen the delirium in COVID-19 patients, which is far exceeding what I've seen in other patients. I don't know whether it's something to do with the COVID, but it could be because of neuroinflammation, which we know happens. We know there's immune dysregulation. Maybe the hypercoagulability that you see is contributing. But I suspect a lot of anxiety, a lot of depression associated with the diagnosis, the isolation, non-communication, staff don't communicate. patients see people in space suits. They don't know who they are talking to. Staff meet patients as little as possible and often give psychoactive drugs to sort of sedate patients. So maybe all of these things are contributing to delirium in COVID-19, right? So in 2021, delirium in the ICU, there are lots of some questions still to be answered. Is it something that intensivists should do? Of course, we have to do a lot to prevent and treat ICU delirium. But at what stage does it become neurological disease and we should seek neurological consults or a psychiatry consult? How should patients who had delirium in the ICU be followed up after ICU discharge? Because we've seen that they do need care and there is a transition to cognitive impairment, and maybe some interventions in the post-ICU discharge period may reduce the incidence of further cognitive dysfunction. So the implementation of delirium detection, treatment, and prevention still remains a major challenge for healthcare. Thank you very much for inviting me, and thank you for listening.
Dr. Mahendra, you need to unmute yourself.
I'm so sorry. Yeah. Thank you very much, Dr. Grover and Dr. Devatia. Very comprehensively presented and no overlaps. Yeah, so we have got quite a few questions. Can we go ahead with the questions now?
Yeah. So, Dr. Mahendra, you want me to take a few questions?
Yeah, sure.
Yeah. So I'll read the question which has been asked by Dr. Abhay Jain. Can DT be preventable by giving alcohol? I think ethically, we don't recommend use of alcohol for prevention of DT. So there are ethical issues for recommendation, and if at all you are trying to use that, it should be considered that in patient, if you're trying to use that for treatment, you should be very, very cautious and discuss the ethical issues involved there with the family, and that should be one of the last thing to consider. I have never used it. Dr. Paresh Shah has asked how to treat delirium due to hyponatremia and any role of oral sodium in such patient when fluid restriction and when IV fluid is needed. Again, we need to understand that hyponatremia is a broad thing, and anything less than 120 is very, very alarming. So anything between 130 to 135, you can just go for the fluid restriction if that is not contraindicated due to the so-called dehydration. Otherwise, you need to understand that you can use oral supplement, you can use hypertonic saline, but when you're correcting hyponatremia, you need to be very, very clear that you're correcting it very slowly. You're not going very fast in correcting the hyponatremia, otherwise you can have centropontine myelinosis. So in that's where, and when the fluid restriction, when to give fluids. Again, we need to understand if there's a hyponatremia and if you want to give IV fluids because of the dehydration, you need to be very, very cautious there. Maybe you need to, in selecting the fluid again, you need to be thinking about using, if you're using saline, you should be using a hypertonic saline. Kashish Thapar has asked, considering the hypothesis of high glutamate and increased NMDA sensitivity in alcohol withdrawal delirium, is dextrose helpful in shunning excess glutamate? That kind of a thing has not been evaluated to best of my knowledge. Basically, here we talk about more of reduced GABAergic functioning in alcohol withdrawal. So when we are trying to manage with benzodiazepine, we are trying to correct the GABAergic imbalance. I can understand that is related to the glutamate, but primary mechanism which is understood as is a GABAergic dysfunction. And and the next question is by Dr. Paresh Shah. When anti-craving agent should be administered in alcohol withdrawal delirium? After how many days of delirium symptoms subside? Any guidelines? Again, there are no, to best of my knowledge, again, no specific guidelines with regard to when to start. But it's always better that once the patient is stabilized, you have been able to taper off benzodiazepine, and you're sure that patient is now motivated to abstain from alcohol. He is physically stable. That is the time you can consider using the anti-craving agent. And again, you need to be again very cautious what kind of anti-craving agent we are choosing, because that will again determine when to start. Dr. Deepak Ghormode has asked that what is the rationale for use of anticonvulsants in anti-alcohol withdrawal delirium period to prevent or treat delirium. Again, here we need to understand that when we're trying to talk about alcohol, use of anticonvulsant, these are not the first line agent. Earlier, when the benzodiazepines were not available, these were tried, but nowadays these are just the exemptive medication. When you cannot use benzos, then only this comes into picture, not as a routine procedure. Kashish Thapar has asked, what are the dosing consideration for managing DT with patient with renal failure? Again, as such, the short-acting benzodiazepines like lorazepam, they do not have much of renal clearance. So that's not a major issue. But again, you need to understand when the patient has renal failure, especially if it's a chronic renal failure and it's a severe kind of a renal failure, the eGFR is very, very low. You have to be very cautious in titrating the doses of benzodiazepine. You cannot go as fast as those with so-called preserved hepatic and renal functions. Then what is the role of glucose or fructose in DT management? Pramod Thakre has asked, see, when you're trying to manage nutritional deficiency in patients of delirium, you can use glucose or fructose, but we need to understand this should be considered only after you have given the thiamine, because otherwise these can precipitate Wernicke's encephalopathy. That is the thing which we need to remember. What is the treatment of resistance protected alcohol withdrawal syndrome, and what is the dose of benzodiazepine for them? How long the benzos should be given in protected alcohol withdrawal syndrome? This is asked by the Madhav Raje. Again, it's a protected delirium. You need to understand that if the patient is not responding to benzodiazepine, then you can start trying combination. And usually what, in my experience, we often use, if patient has not responded to benzodiazepine for 2-3 days or the agitation is not getting managed, we combine benzodiazepine with low dose haloperidol, and that works better. Again, the duration of benzodiazepine use will be determined by the so-called till the duration the withdrawal is persisting. So you need to keep that in mind. Dr. Mendru, can I take a break for a few minutes and I'll again come back? Is it, or should I continue? Okay. Is paliperidone advisable in DT with hepatic dysfunction in alcoholics? Again, we need to understand that there are evidence for this kind of use of paliperidone is only limited to small case report and case series. So we need to keep that in mind. The level of evidence is low for that. This was asked by Dr. Pramod P. Thakare. And Dr. Dipankar Bagh has asked, do antipsychotics in the management really helpful in delirium in ICU? And can delirium be predicted by pre-operative patients? Yes. So coming to the second question, can delirium be predicted in pre-operative patient? Definitely, we have different predictor formulas also now available, and evaluating the patient for all possible risk factors can help you in predicting delirium. So that needs to be kept in mind, and that is why there are a lot of trials about use of pharmacological and non-pharmacological agents for prevention of delirium, and we have a lot of data on that. And non-pharmacological measures have been shown to be very effective in prevention of delirium. Even haloperidol has also been found to be effective in prevention of delirium. And in recent times, melatonin also has been found to be efficacious. And in terms of use of antipsychotics in management of delirium in ICU, again, we need to understand that most of the patients with ICU delirium have hypoactive delirium. So in hypoactive delirium, there is no role of antipsychotics. It is only when the patient is agitated, that is where the role of antipsychotics come in. So definitely they have a role, but only in hyperactive delirium. Yeah, I'll stop here. If sir wants to take few questions, then again I can come back.
Okay, thank you. So Dr. Ajay Gowri is asked, between haloperidol and quetiapine, which is the preferred drug? So haloperidol is in my practice, I would use haloperidol simply because you've got extensive use and experience with haloperidol. And when you give it for short periods in the ICU intravenously, you don't get those problems of extrapyramidal side effects and all those sort of things which you get with chronic oral use. The only thing that you have to look out for is QT prolongation, which is not difficult to monitor in the ICU. So I guess there are some advantages to quetiapine, but overall experience with haloperidol in agitation is probably greater. Then Dr. Rupsna asking about loxapine, an antipsychotic with atypical-like effect, is available in drops, useful for managing delirium. Any evidence or experience? Not to the best of my knowledge. certainly no experience, and most of the trials have not been done. I have not come across a trial which has used loxapine in the ICU. Jignesh Chandra Chaudhary asked, what should be the pharmacological agent for hypoactive delirium? Like it was emphasized, there is no, please don't use pharmacological agents for hypoactive delirium. Keep looking for the cause, get rid of any sedatives, and also keep in mind that, in patients who are in the ICU who've had shock, renal dysfunction, liver dysfunction, the drugs that you use, they take much longer to clear. And you'll have small doses of drugs hanging around even after 3 days, 4 days, 5 days, 1 week. So sometimes you just have to be patient and hope these patients will get better. So the pharmacological management should be reserved for treatment of hyperactive delirium or agitation. Dr. Ramesh Babu asks, what is the, I think that Dr. Grover would be better off to take.
Sir, should I start again?
Yeah.
Okay, thank you, sir.
Sure.
Yeah. So when it comes to the issue of haloperidol and quetiapine, just I'd like to clarify the risk of QTC prolongation with quetiapine is slightly higher than haloperidol. Let's not go with this impression that QTC has lower risk, the quetiapine has lower risk. We need to remember that. And the level of evidence for haloperidol is much, much larger than quetiapine. That's the issue which we need to remember. Dr. Ramesh Babu asked that when the pattern of onset of symptoms stands as a cardinal feature, how do I distinguish delirium from dementia? Again, the most important thing is when you're taking the history, you need to focus on, is there a further worsening? Because patient with dementia will have cognitive deficit, so you need to understand that is there a further worsening on whatever was the baseline for the person. So that is where you have to focus on while you're evaluating delirium in patients of dementia. And along with that, you will have behavioral symptoms in these patients. And what are the most common causes, common reversible causes in geriatric delirium patient? Again, we need to understand the most common causes which are found in elderly patients for delirium are electrolyte imbalance, nutritional deficiencies. So if you look for these, you can reverse these and the patient can improve. Hyponatremia is one of the important cause there. Dr. Chala Bharti has written, lorazepam itself can worsen sleep and can trigger delirious behavior. What is the treatment for that and what can we give for sleep? Okay, we need to understand that sleep here in patients of delirium is part and partial of the whole syndrome, sleep disturbance. So once you are using haloperidol itself also normalizes the sleep. In recent times, as I said, evidence is emerging that melatonin may be useful. At least we have used melatonin in patients and we have found it useful in restoring patient sleep. But again, I would like to emphasize the evidence from RCTs is not very convincing for the time being. Dr. Roop Sidhana has asked that if patient requires physical restraint in a patient of delirium, what to do? What I've said that we need to avoid restraint, but if there is no other option, use restraint for the shortest possible duration. And whenever you think the patient is cooperative, the effort should be made to remove the restraints, and restraint should be made in such a way that patient is comfortable, patient does not injure himself because the patient is very, very agitated. And regarding your previous question about use of loxapine, again, the evidence is in the form of case reports and case series. There are no randomized controlled trials or no open label trials for loxapine. Dr. Ramesh Babu has asked why male gender is independent risk factor in delirium. Again, this is an association which is seen in different studies. So no specific cause has been reported, but it can be also that males are often overrepresented in people who come with substance abuse, who come to emergency. So that, but no other specific cause that I am aware of. Talked about magnesium, its role in so-called, how does it affect the efficacy of thiamine? So I'm limited to that. I'm not going to the whole psychiatry here. And the Kashish Thapar has asked, in case of alcohol withdrawal delirium with systemic comorbidities, when presentation of delirium is with low psychomotor activity, what are the neurological mechanisms that are at play, and is the doing of dosing of benzodiazepine for replacement different here, since the guidelines recommend mild sedation in case of delirium tremens? Again, you need to understand that when you're trying to manage delirium tremens here, you need to understand that psychomotor activity will often fluctuate. And if you are seeing a hypoactive kind of a picture in a patient of delirium, especially alcohol withdrawal delirium, again, you need to understand you're not just looking for alcohol, but also you're targeting the withdrawal symptoms. So if the withdrawal symptoms are not there, it is hypoactive delirium, then most likely there are underlying organic causes and you're dealing with a mixed kind of a delirium rather than a just an alcohol withdrawal delirium. So there the management will be guided by how much you attribute the delirium to alcohol withdrawal or to the underlying medical cause, and accordingly you can choose the medication. If you are attributing the delirium to alcohol withdrawal, again, it is better to go for so-called symptom triggered. So if you're not seeing too much of symptoms of withdrawal or DT, then go slow. Start with a very low dose. What is the role of, what is the rationale of using antipsychotic in delirium inspired anticholinergic activities and cognitive impairment of almost all antipsychotics? This has been asked by Sibin Mohammed. Again, we need to understand that anticholinergic properties have been reported for various antipsychotics, and definitely some of the antipsychotics have themselves been shown to they can worsen delirium. But because of their dopaminergic properties, they help in patients with delirium. So that is why that is the main reason why they are being used in patients of delirium. What is the commonest cause of delirium? Again, in Indian context, the commonest cause which has been reported is sepsis and metabolic disturbances. So that is where I will leave it. And when will the physician realize that the delirium is their problem and not of psychiatrist? I totally disagree here that delirium is a problem of the psychiatrist, which is occurring in a setting where physicians are managing, and we should be involved in management of delirium at every place. So I totally disagree with the observation here. Good going, keep it up. Is there any psychiatric disorder which presents as delirium? Any reports can panic or conversion disorder rarely present as delirium? In terms of psychiatric disorders, we need to understand depression, substance abuse disorders are reported to be the risk factor for delirium. In terms of other psychiatric, delirium mania has been reported in the literature. Somebody is asked in relation to that also about the Bell's mania, but now it is understood as more of a hyperactive delirium. So these are the terminologies. And in terms of conversion disorder rarely presenting as delirium, you need to understand that delirium is an independent diagnosis. So conversion disorder presenting as delirium may be there. You need to understand that as I presented ICD-10 and DSM-5, ICD-11 and DSM, if you're attributing delirium to underlying psychiatric disorder, it cannot be delirium. It has to be an underlying physical disorder. So you have to be very clear in that. Why there is widespread use of haloperidol for pharmacological management when PAD guidelines recommend atypical antipsychotics? Why are we not adopting to PAD guidelines in our setups when there is robust evidence for non-pharmacological approaches and analgesia first approach decrease our dependence on sedatives? I think the question is well taken, but we need to understand that PAD guidelines have not specifically said that you need to use atypical antipsychotics. And as I've already emphasized, when you look at the evidence base for haloperidol is much bigger than the atypical antipsychotics. No atypical antipsychotics is able to match the evidence base which is available for haloperidol.
I just add something here.
Sure, sir.
So the PAD guidelines actually do not recommend routine use of antipsychotics at all, whether typical or atypical or haloperidol.
Yeah.
And after the publication of the PAD guidelines with 2018, we've had this trial which I mentioned, the MEND ICU trial, the MEND USA trial, which is the largest trial so far comparing haloperidol and other antipsychotic with placebo, and that actually shows no difference in either. So I think we focus on non-pharmacological and use, and like we mentioned, you either stick to haloperidol or something for hyperactive delirium and agitation.
Dr. Devartia and Dr. Grover, we are running out of time, and also I think we've covered most of the questions, because everything else that comes after this, these were questions which were put forward before your talk began. So most of it is covered, and some questions related to delirium which have come in after your talk began, you've covered all of them. Now we are running out of time, and we need to select the best question according to both of you and our chairpersons.
Yeah, Dr. Mahendra, I have put the message in the group.
Just let me have a look. Yeah, thank you. So the question chosen as the best question is by Dr. Ramesh Babu. When pattern of onset of symptoms stands as a cardinal feature in clinical diagnosis, what are the additional clues we need to look for while dealing with a case of delirium in a patient of dementia? So I guess we are unanimous about that.
Yeah, I think so.
All right. So congratulations, Dr. Ramesh Babu, for asking the best question. Yeah, I would request the Banai team to take over now.
Thank, thank you all for joining us today. We hope to see you again soon. Please block your date for Tuesday, 30th March 2021, same time from 8 p.m. to 9:30 p.m. Also, based on many requests that we have received, we would like to inform you all that all our previous webinar archives are now available on our YouTube channel, Banai India. Do send us your feedback and comments, if any, on info@banai.org.in. Till then, stay safe. Good night.
Thank you. Good
Thank
night.
you very
Thank
much.
you. Good night. Yeah.
Good
Thank you.
night.
Good night. Nice session.
Thank you.
Thank you.
Thank you.